going to talk now about the public piece, and that's what I'm going to talk about here. So the private side, you know all about the support of this move to quality, massive investment in sensors, systems, IT, so on. The philanthropy side is not discussed very much today. Hugely important is quality of research, quality of teaching, a very important part of this whole story. The interface between these three elements, all with very different aspirations, is something worth study. Sometimes works extremely well, sometimes a few sparks, and occasionally, as I found out, a major explosion. I'm going to only talk about the public side. So the question is, can the public side do it? Can the government of Ontario do it? The answer is a resounding yes. This is wait times data led by the government, very clear-cut direction from the Premier, very clear-cut direction from the Minister of Health. This is what we're going to do. Here's the pay-for-performance strategy, here's the public reporting strategy, here's the involvement of physician strategy, etc. These are data to show the original Big Five. You can see the years across the horizontal axis, getting these down to the objective of 90% percentile to the target in an extremely successful way. Now, out of that, obviously don't try and read this, out of this grew by design, this whole suite. And the key line to read is 1, 2, 3, 4, 5th from the right, which is showing that virtually all of those are within the 90th percentile hitting the target, with one exception, which you'll see if you read and that is MRI. If you look at the pediatrics, again, same column to see that virtually all within target. That is a huge success story, from the worst in Canada to the best in Canada. So on the leadership role, as I said, very, very clear-cut, very distinctive, very well-funded. Where was the innovation in this? Not a heck of a lot. Pay for performance is not innovation. I mean, we copied a lot of ideas from a lot of other people. Possibly the one innovation was really understanding the point that so many people miss, and that at the root of all of this stuff that we're talking about here is changing physician behavior. And how to change physician behavior, how to get physicians involved, and to lead this, which is what was done, and as a result, why this was so successful. Now, look at this is the ER data. If you look at the far diagram, far from me, this is budget versus actual. You look at the wait times, and if you look at the less complex cases, you'll see that budget versus actual is virtually overlaying. You can't read it across the bottom of the years, and the final year is, of course, the year of the election, at which point it'll hit the target by design. So that looks terrific as well. We are, of course, in full election mode, a year to go. Come on this side, these are the complex cases, but not as many cases in the ER. Same as wait time data, but not only do you see separation budget naturally, you see it's getting worse. So that's interesting. So you look at that, and that's very simply the ARC issue, and if you look at that data, you'll see it's flat for 3 years. I just recently saw an agenda for one of the business meetings at the ministry, different people, same questions, same agenda 3 years later. So what's the difference between this and the very successful campaign? This is a complex story, but one thing is very clear. When this was launched, Premier said one thing, Minister said another thing, the LINs did a third thing, right? Confusion from day one. Huge amounts of aging at home money, remember all that stuff? Just disappeared. By the way, all to good use, but unfocused, and trying to recover from that is very, very difficult. So overall, a very successful story, and showing that a public entity can, in fact, play a very important role in this whole story. So what can you bring over now to the discussion of quality? You heard the deputy this morning describing what I think are terrific programs in this province, things we've been talking about for years and years and years, and they are almost here. So the key issue is governance, right? So the Ontario government, as the deputy mentioned, somebody has to bring together this plethora, federal, provincial, special groups, collaborative of academic health science centers, on and on, everyone talking about quality, which is good. It was a few years ago, nobody was talking about quality, just a few diehards who actually knew the numbers. So this has been a very strong step in the right direction, but somebody's got to do this, and it's a question of timing. If your organization has just spent 2 years, 15, 18 months, trying to take, say, 150 indicators, targets, down to 10, which means you've got to look at the evidence behind each one and argue it out, a very important part of the process, right? So you bring people into the game, and you end up with your 8 indicators you're going to go with, and the government arrives and says, oh, by the way, here are the 6 we're using, and by the way, sorry, they don't coincide with yours. You know, people aren't going to accept it too well. So you need to lead out front. So we need this in a very big hurry. It already mentioned that there will be an entity, and hopefully with a visible leader, that will provide the direction for quality, and I think what you heard there is extremely encouraging. The issue of governance and hospital boards is very important. It is, of course, not, and everyone's stressing this, the only part of the quality game. It's also a site at which you can do a huge amount of harm, and you're all aware of all the figures, so I'm not going to go through them. So a few years ago, I went to the OHA, Ontario Hospital Association board, and said, in my view, minimally 50% of the boards of the hospitals in this province didn't know what they were doing. I actually said a little more forcibly than that. There was a deathly silence, and they all turned to Hugh McLeod, who was the ADM sitting next to me, to contradict me, and he kept silent too. Because in the wait times game, I'd say to a board, you've got good ophthalmologists here? Oh yeah, world famous. Everybody's world famous, you know that, all right? So I say, okay, tell me as a board the percentage improvement in vision following cataract surgery in your hospital. Dead silence. I had no goddamn idea. Incidentally, 90% of the hospitals would give the same reply, right? They don't know their outcomes, most of them. I'd say to them, are you aware of the fact this is not Biafra, this is Ontario, but if you have your lung out in hospital A, 13.4% mortality rate in hospital, hospital B, 3%. You know that? What? And on and on and on goes. By the way, who do you think is responsible for all this? Oh, you know, it's sort of the docs. Oh, yeah? And you just reel off the numbers. So now, to their great credit, OHA in the last few years has spent a huge amount of time on educating boards, bringing this up to a much higher level. There have been seminars after seminars. But it's very interesting. In some of the recent little handbooks that came out from the OHA, one of the claims of success of some fairly important hospitals was that they just established a quality committee at the board. You've got to be kidding. Well, I thought they were there for the last decade. So we have a long, long way to go. You can't do this in the hospital game without a very strong oversight of the board and appropriate board quality committees. So now, as you heard the whole discussion now, the move now to chronic disease management in the community, you know, all the reasons for that, that's where the money is, and that's where the problems are. So that's easy. So now let's move over to discuss governance of primary care. Slight problem, huh? There's none. Slight problem. So this is primary care. I don't do Friday nights anymore. I don't do palliative care. I don't do hospitals. Could you imagine trying to do anything, any of the businessmen in the room, with your staff behaving that way? They'll come to work when they feel like it or not, and they do it or maybe not. So this is becoming a huge problem. Talk about productivity, right? You've got a boutique industry now. What I'm going to do, what I'm not going to do. And by the way, I'm going to choose. So you simply cannot do this. You can't run a system this way. You have to have some form of, I'm not talking about Stalinistic governance, but you have to have some governance. So we'll talk about the LHINs at the same time. Of course, no one had the spine to do the obvious, which when LHINs were created, to give them the governance of primary care in that room. They didn't have the guts to do it, right? Now, I don't think I'm misquoting, because several people told me I wasn't at the meeting. The leader of the opposition has said he'll blow up the LHINs. To loud applause, by the way. So this is a rather interesting point. A great opportunity now to get a few things straight. Whatever it's recalled, whatever numbers there are, whoever gets in, you have to have governance of primary care. Secondly, to stop the parallel functions of CCACs and LHINs, which is complete nonsense, and make them all into one. So that's a very interesting part. So this whole issue, you can't run these things. It's just shown you that the public side has a very important role to play. This, by the way, a part. I mean, everything else has to go on at the same time. But that's one key lesson. This is the other key lesson, which is almost the key lesson from the last go around. Wherever I am in the world, anywhere, discussing any major shifts in healthcare policy and so on, regardless if it's publicly funded or privately funded, to say to them, what are your biggest problems? The answer is identical. Doesn't matter, you know, talk about Germany, you could do wherever you go. The doctors. Always. Doctors have great trouble in changing. Well, the fact is that physicians supported this wait time story I just showed you very well. And in fact, the whole issue here is changing physician behavior. And turning out computers and systems ain't going to work unless you pay attention to what is absolutely central. So how do you change physician behavior? Because this is the biggest question, whether you're in India or wherever you are. It's easy, right? We just showed you how to do it, right? It's dollars, data, and embarrassment. That's all it was. Now, don't forget, it's in this circumstance, our peculiar public-private mix we have in this province, right? But if there are positive financial incentives, the data which I was showing you is probably, that's off the website, is not touched by either an elected official or a bureaucrat. So it's good, solid data they can rely on. Embarrassment is, I arrive in Ottawa, in the Premier's writing, I go to a Lynn meeting and say, you are stone last in every category. That's the front page of the Ottawa newspaper the next day. You can imagine how popular I was. It works all the time. You want to use that very sparingly. Just make one final point here, and that's the issue of accountability in this whole quality story. To get all this buy-in, which has been so successful, it's, by the way, it's not your fault. This is not about blame. This is about the system. You operate on the wrong leg, don't worry. It's the system, not you. You gave the wrong drug, you killed the patient. No, don't worry. That's the system, not you. I agree with that. I mean, I agree that you want to build systems to prevent accidents. But Henry Kissinger's famous line was, when I want to call Europe, who do I call? And, you know, when you want to get some accountability, who are we calling here? We can't call the system, right? So when the deputy described what's coming down the pike in Ontario, it is clearly at the board level and hence at the CEO level, and you mentioned variable pay and so on, and down through the organization. So I think we need to just beef this up. You know, we get more flies with honey instead of vinegar and all that stuff is lovely. Let's just get a little more serious about accountability now. And as the deputy mentioned, I think that's what's going to happen here. The final slide I'll show in transferring what we learned and how successful that was is the issue of the public, which has come up over and over again here. Let's just look at a few things. The first issue is privacy. So you heard about diabetes, right? So that diabetic data set, the most important person to have access to that, of course, is the patient, right? The patient's going to run their own life, and most diabetics do, right? The second most important, by a long, long way, is what I will call the nurse practitioner, the generic statement there. And by the way, all the discussions of efficiency and cost and so on, there's your answer. The third then, possibly on occasion, the family doc, rarely a specialist, rarely a hospital, plus, of course, a dietitian, plus social worker, possibly. They all have to have access to the same data. Otherwise, it ain't going to work. I mean, that's the whole point. So there's your privacy, right? Now, I was delighted to see in the papers 2 or 3 days ago, a big advert explained to people, do you want to have your data shared? Do you want to opt out? So that's starting to educate the public what a huge issue the privacy piece is when it comes to shared data. And people, of course, are very keen to protect their own data unless it's the American Diplomatic Service, in which, of course, I think nothing of breaking their privacy. The second piece the public has to understand to demand from the government that they continue the right way, which they're doing, is to understand the functions of the trade union. I wanted to ask that question of our excellent luncheon speaker, right? So trade unions form to look after the interests of their members. That's why trade unions form. I'm not a sociologist, but I think that's pretty obvious, right? No disrespect to the OMA, right? They looked after my fee schedules, but they are there to look after the docs. Who is looking after the patients and these unbelievably bad quality issues we have in this province? The way it's set up now, it has to be the government. Public got to understand that. That's why the government is leading these quality charges. All trade unions clothe their own self-interest in noble words, whether it's QP or the RMA. Are we here for the patients? Are we here? That's not true. All right, I'll give you example after example after example. I'm being a bit hard on that, but there's a reason for that. Now, the next thing the public needs to understand is what is going to be crucial, and this was touched on frequently. That's the next OMA negotiation, which occurs just after the election, all right, by design. What is the signal for success for the government in the OMA negotiation? Anyone, all right? I've been involved in this for years, right? It's easy, no strike. Isn't that terrific? I mean, the businessmen will just cringe when they hear that. All right, no strike, great. And so, surprise, surprise, every year, far greater than inflation. This year, payout relative to inflation, unbelievably wide apart. And on and on. Because if you negotiate price, goodbye, here's the money, good luck, guess what happens? I wouldn't have the heart to inquire of the deputy how many $1 billion he's over already, but I know for sure it will be. You can't do it any other way. Those days are over. You now have to negotiate outcomes, and particularly quality outcomes. Here are the 6 targets for Ontario. You don't meet these 6 targets for Ontario, we're going to pay you 80%, not 100%. Guess how quickly it will change. So this is a very important issue. The public have no idea how these big, huge powerhouses. I wanted to ask the lunchtime speaker how he coped with the obstructive trade unions. And what I was going to tell him, 70% of anesthetics in the States are given by nurses. In this province, 0. Very strong trade unions, all right? So that's another issue that the public needs to understand. There's another point about the public. We need to be very careful about semantics, right? Most of the public know what the hell you're talking about when you talk about quality. They use quality in a different sense. Oh, we're measuring unnecessary bladder infection when you put a urinary catheter in. Oh, we get that. So anything you're measuring, they'll get. I know from the quality of this is cotton, not silk, but that's not what we're talking about, right? Be very careful about the word. I see now the word fidelity creeping into the literature. Well, the public uses fidelity in a very different sense. So try and keep the language as simple as possible in discussing this with the public, and we need to give them the facts. So I've been advocating that the government, the last go around, they should run on quality. They're obviously going to run quality now. So they all love our system. How's that possible? I said, why don't you just tell them what's going on? You heard about diabetes, right? 6 very simple interventions, right? Regular blood sugars, annual eye exam. Nothing too difficult. About grade 6 education can do it. And with that, amputations down, renal transplants down. I mean, good, solid data. All of you know what percentage. You'd think, what, 95% of diabetics in this province on those protocols? Lucky if it's 50. Unbelievable. The public's got to know this. Oh, you can't tell the public, you'll frighten them. No, if you don't tell the public how many planes are crashing, thousands of people getting killed and maimed every year in hospitals, approximately 50% getting optimal treatment in hospitals, like what happens to the other 50%, the pressure of the public on the government is not going to be as high as we need to get it. I, therefore, am very optimistic. I think the public role here is going to be follow on the success of the wait times, learn the lessons from the wait times. You've heard the program, but the key point now is to get it done. So let me finish with the old cliche. Talking is easy. Planning, strategic planning, relatively easy. Execution, extremely difficult. Well, let's get on with the job and get it done. We need to know who's leading this thing the deputy was talking about, who are the people around him, what's the pay performance, what are the targets. And I'm actually very optimistic. I've been away photographing lions for a while, came back, I was very, very impressed with the progress that's made. Thank you.